Well, carefully see the upper part of the left lung, where you will find that there is an area where the bronchovesicular markings are absent. At the junction where they are present and where they are absent, you can see the border of the lung. Now, where they are absent is a pneumothorax. It is a life endangering, time critical complication of chest injury, and you must immediately treat it by decompression, either by a needle or intercostal drainage. The other signs of pneumothorax are that the trachea and apex will be shifted towards the opposite side, the breath sounds will be absent, and there will be a tympanatic note. Today we will cover chest injuries. The chest injuries are suspected if there is pain in the chest following injury. The possibilities are intercostal nerves paralyzed, so the intercostal muscles paralyzed, a rib fracture, an intrapleural space occupying lesion, the contusion of the lung, which is called as the submariner's lung phenomenon, air leak peribronchially, so that's called as peribronchial emphysema, which goes through the mediastinum into the suprasternal space of Berne, or aspiration. So these are the reasons of breathlessness. Then there can be a bleeding into the pericardium, preventing the dilatation of the heart and end diastolic filling. That leads to cardiac tamponade or shock because the heart cannot pump out blood. Then there can be lot of bleeding and hypovolumic shock. Then the diaphragm may rupture, there is diaphragmatic hernia, or below the diaphragm the liver or the spleen can rupture. So these are the problems that can occur. So only the rib fracture first, only the rib pain. So there is only pain and there is localized tenderness. Now this tenderness can be because of a contusion or because of a rib fracture. So the difference is that if you put antero-posterior pressure and there is tenderness at this site, you are putting pressure antero-posterior. So that means you are causing this rib to spring, and there is tenderness at this side. So this indirect tenderness indicates a rib fracture. It is called a spring test positive. Now in this fracture, you have to immobilize. So the lower ribs will move along this axis, and they'll move like a bucket handle, okay? And they will move first. In inspiration, they will move first. And then they will be followed by the upper 6 ribs, which will move at the axis, passing from the costo-transverse and costo-vertebral joint. So on this axis. So this movement is like a pump handle. It will increase the transverse and the antero-posterior diameter of the chest. So if you, remembering that the lower 6 will move first, if you immobilize the lower 6 in expiration, the upper 6 will be automatically immobilized. This was described by Dale, and so the Dale's method of strapping is that the lower 6 ribs, regardless of the site of fracture, in expiration. And the direction of the strapping is from the most convex portion of the rib, which is usually in the mid-axillary line, to the site of tenderness, to the site of fracture, because this will produce compression at the fracture. So these are the two things in Dale's method of strapping: lower 6 ribs in expiration and from the mid-axillary line towards the site of tenderness. Now the patient is presenting with breathlessness. So from outside in, The intercostals are paralyzed, the rib is fractured at two places, therefore a segment is flail and moving in opposite direction to the rest of the chest wall in inspiration and expiration. There is an intrapleural space occupying lesion, either a pneumothorax or a hemothorax or a pyothorax. There is injury, laceration of the lung with the inflammatory edema in the lung, which is called a shocked lung. There is leak, peribronchial emphysema or leak, which is evident in the suprasternal space of burn, or you can see air in the mediastinum. And finally, intraluminal, there is aspiration. So these are the reasons of leak. This diagram shows you them. Intercostal paralysis, double fracture here, intrapleural space occupying lesion, shocked lung, pulmonary edema, peribronchial emphysema, and aspiration. These are the reasons of a problem. So what will you do? Intercostal paralysis, you will put the patient on intermittent positive pressure respiration and you may need a ventilatory support. Flail chest fragment, you have to either put this flail fragment in traction, which is called as towel clip. You use a towel clip for this traction, or you have to internally stabilize these fractures. Intrapleural space occupying lesion. Intrapleural space occupying lesion here, the air or blood, the blood or the air. Now this is very tricky because this is the collapsed lung. Collapsed lung is like acting like an ambu bag for the normal lung. And because of this, there is ventilatory failure. Secondly, the entire right-sided cardiac output of pulmonary artery is passing through this and returning back to the heart without getting oxygenated because there is no oxygen here. So there is blood here but no oxygen, blood here, no oxygen, no air, and there is air here but no blood. So ventilatory perfusion dissociation. So here you have to put the patient on IPPR, intermittent positive pressure respiration, and you have to do an intercostal drainage, negative pressure intercostal drainage. Then we go to the shocked lung. You have to give steroid, you have to give oxygen, you have to give ventilation. And this phenomenon, shocked lung, was seen in submariners where the shock waves from depth charges of destroyers used to cause multiple lacerations in both lungs. And here you have to give steroid, oxygen and ventilation. Then there's peribronchial emphysema. You put a suction drainage in the suprasternal space of burn. Suction drainage in the suprasternal space of burn, and you may have to give bronchodilators. Aspiration, you have to prevent aspiration and you have to treat it by suction. Chest physiotherapy and tracheostomy. Now we'll cover this physiology of the flail chest. I've already told you this whole fragment is moving opposite to the normal chest. Therefore, that is called as paradoxical air movement. Because of that, there is less negative pressure in aspiration in the collapsed lung, in the flail chest side as compared to the opposite side. So the air moves like this red arrow. Then in expiration, there is more positive pressure in the normal lung as compared to the affected lung. Therefore, air moves like the green arrow. So this air is moving across the carina from one lung to the other and no air is coming from outside. Therefore, there is ventilatory failure. This to and fro movement from one lung to the other is called as pendular air movement. And you have to treat it by intermittent positive pressure respiration intermittent positive pressure respiration, and stabilizing the flail fragment. Then this is the physiology of the intrapleural space occupying lesion, which can be blood or air. Air will give you a tympanatic note, blood will give you a dull note, there will be no respiratory sounds, and first of all, this collapsed lung will start acting like an ambu bag of the anesthesia trolley for the opposite lung. So in inspiration, it will give air, in expiration, it will take air from the affected lung. No air will come from outside, therefore there will be ventilatory failure. On the other hand, entire right-sided blood, this is the collapsed lung. So entire blood from the right side of the heart without getting oxygenated will pass through the collapsed lung back into the heart, because the peripheral vascular resistance in the collapsed lung is far lesser than the normal lung. So this is called as ventilation, perfusion, dissociation. Air in the normal lung, blood in the collapsed lung. So there is dissociation between ventilation and perfusion. Then this is the cause of breathlessness and its management. Now we move on to shock. Shock can be hypovolumic because of blood loss, and this hypovolumic shock, the neck veins will be collapsed and the CVP will be low. To treat it by hemostasis, internal or external bleeding has to be stopped, and you have to replace blood by blood as soon as possible, as fast as possible. The second reason of shock is that there is blood in the pericardium, called as cardiac tamponade. This prevents the ventricle from dilating, and therefore the end diastolic volume becomes lesser, and therefore the cardiac output becomes less, and the patient goes in cardiogenic shock. But because of the back pressure, this right ventricle will also not dilate. So because of the back pressure here, the neck veins are engorged and the CVP is high. So the patient is in shock and CVP is high, neck veins engorged, it's cardiac tamponade. You will have to do a paracentesis and pericardiocentesis and hemostasis. In the hypovolumic shock, you will have to treat it differently. Then there can be visceral injuries to the esophagus that can be ruptured. It's usually ruptured when a drunk patient vomits in a cold night. There is hematemesis and shock. You can see mediastinal lymphedema, and you treat it by exploring and repairing. This syndrome is called as Mallory-Weiss syndrome. Then the diaphragm can rupture. You will find bowel or stomach shadow, supradiaphragmatic. Treatment is explore, reduce the herniated contents, and repair the diaphragm. Then there can be a liver or spleen rupture. So this blood usually goes around the umbilicus, and this is called as the Grey Turner sign. Then the blood is in the gutter, right or left, depending on whether it's from the liver or the spleen, and you may be able to elicit shifting dullness. Then, of course, the patient is in shock because of the bleeding. Pain, both are subdiaphragmatic. So pain is referred to the shoulders. In the liver, the pain is referred to the right shoulder and it's called as Troyer sign. In the spleen, the pain is referred to the left shoulder, it's called as Kehr sign. Treatment is you explore it, you put crushed muscle with lot of thromboplastin in the wound, and then you apply pressure by the suture, deep tension suture, so that because the pressure here is higher, there is no bleeding into this area. So this is how you deal with liver or spleen rupture.